Uh, what I'd like to do for you today is talk to you about a little project that's been going on in our lab for the last 5 years, which deals with the dimension of time in the treatment of cancer. The way I'll sort of talk about this is basically introduce you to the disease that I treat and I spend a lot of waking hours dealing with, probably some sleeping hours as well, which is malignant melanoma. Tell you where we are today in the treatment of this disease, particularly in the metastatic sense. This is when the tumor is widely spread throughout the body. And really spend most of my talk telling you about what can more be done and the things that we've done to try and improve outcomes of patients here and now today, and kind of finish with a little bit of a summary. So without further ado, what is malignant melanoma? Melanoma is a cancer of the skin that William Osler refers to as the cancer that gives cancer a bad name. It's sort of an iceberg phenomenon where the tumor is flat on the surface of the skin and sort of has a depth below the surface of the skin. And this depth is really an important aspect of this disease, because when the surgeons take these things out for us, as you can see in this animation, what they try to do is to really capture that bottom piece that lays right under the surface. And this is really where the disease, sort of where the badness of it comes, because as the tumor invades into the deeper and deeper layers of the skin, once it reaches the levels of the lymphatic vessels that drain every square inch of our skin, the tumor cells gain sort of a superhighway access to the rest of the body. The cancer cells leave the skin, enter the lymphatics, and then populate the lymph nodes, which are sort of the sieves where a lot of these things are filtered that come from the liquid from the skin comes through. And from there, they enter into larger lymphatic vessels that drain into the blood supply, and then through the blood, the cancer gains access to the entire body, and the cancer becomes metastatic. Once metastatic, malignant melanoma is a deadly disease. This is one of the most aggressive malignancies in nature for which there is very little treatment today. This graph of overall survivors over a period of 20 years illustrates that only about 7 to 10% of patients with metastatic malignant melanoma, when the tumor is widely disseminated, actually survive. The vast majority of them succumb to disease. So what have we done over this? You know, the war on cancer has been going on for 40, 50 years right now. And here are the FDA-approved drugs for the treatment of this disease. Chemotherapy, the original agent approved, was in 1975, a drug called dacarbazine, offers an overall survival time, a median overall survival for a patient who has been diagnosed with metastatic melanoma, of something like 6.5 months. Not a great deal, but that was 75. Immunotherapeutic approaches that augment existing immunity offer us about an 11-month median survival time. And targeted agents, some of which have just been approved, offer us just over a year median survival time. Okay, so we're not talking cures, we're talking some advances better than that of 1975, at clearly not an insignificant cost to society. And in this age of health care cost restraints, this is a significant problem. And the unfortunate truth is, in this year, in 2012, virtually all patients diagnosed with metastatic malignant melanoma, a cancer of the skin induced by sunlight, by UV radiation, die of their disease. In North America, 1 person dies every hour of this condition. 2 will have died at the end of this session. So this is where I come in. My job at Mayo is to put an end to this. So when we looked at this, we said, well, what can we do more? What can we do at this wonderful institution of the Mayo Clinic to put a stop to this scourge in humanity? Go back to basics. I did a lot of basketball. I remember my coach always said, when we're losing a season, we need to go back to basics. So that's essentially what we did about 10 years ago. We started asking, well, what makes melanoma a tumor? Okay? You know, what makes a tumor, basically? Well, there's 3 basic elements. There's a heterogeneous population of cancer cells. There is reactive stroma from the body, normal tissues that come from the body surrounding the cancer tissues, especially blood vessels, and the reactive immune system. The body's natural defense mechanism evolved over 20 million years to react to novel things in the body. And, you know, I treat cancer for a living, so most oncologists like me look at cancer therapy in this type of a sort of a targeted approach, as it were. So the bullseye are cancer cells, and that's what we're trying to destroy. And this is where chemotherapy comes in. You know, dacarbazine and vemurafenib, two agents to target cancer cells and need to destroy this piece. Surrounding is the tumor microenvironment, and this is the normal body that in many ways sustains the growth of the tumor. And around that is the unaffected organ systems, namely the immune system that is co-opted by ipilimumab and interleukin-2, two immunologic treatments that turn on the body's immune system to go after the cancer. Okay? Now, if you're a mouse, and I can test you this, I am your guy for metastatic melanoma, because I can cure mice with melanoma with each one of these things. Unfortunately, I can't cure humans as well as I can. And one of the problems may be that therapy, given in all of these dimensions, has to go through the unaffected organ systems, through the microenvironment, to gain access to the cancer in order to offer a clinical response. So when we first looked at this paradigm, we said, well, you know, how really unaffected is the unaffected organ system? We know these things are abnormal, but is this really unaffected, and is it normal surrounding the body, and namely the immune system? So what we did is, about 7 years ago, we did this very simple experiment. We said, well, let's measure the immune hormones that the body produces in blood in patients that have various stages of melanoma, 1, 2, 3, and 4. Also patients that have benign or atypical nevi, essentially normal volunteers who worry about having melanoma. And measure 27 hormones of immunity and see if everybody that has these clinical conditions is the same or different, right? Makes sense, you gotta start somewhere. So what we did is we measured 27 different things and projected the data as what is referred to as principal component analysis. Each individual patient is presented with a little sphere, and the different stages of disease, melanoma stage 1, stage 2, stage 3, and stage 4, along with the benign conditions, are color-coded. Now, in this very complicated presentation of a lot of data, the assumption is if everybody's the same, all of the data huddles in one big clump. But you can easily see that all of the data in the different colors stays together here, except for this little cohort here. And these end up being the patients with metastatic malignant melanoma. This is the people that die of this disease. So what's different about them? Well, what's different is that the hormones of immunity that are upregulated, that are a much higher concentration in this patient population. Remember, we've always assumed that hormones of immunity in blood are normal in these folks. What this signature of high concentrations of hormones is reflective of is that of chronic inflammation, or as immunologists like to refer to as the T helper 2 cytokine dominance of chronic inflammation. So the normal immune system of a patient with advanced melanoma is not normal. How do we use this knowledge to our advantage? This was published in 2005. So the immune response, or the immune system, is a very complicated instrument. And the way to look at it is that this is akin to an orchestra. There's multiple instruments, multiple groups of instruments, multiple notes, multiple pitches, multiple tempo. But one thing that the immune system does in acute inflammation, and everybody that's ever had a cold knows this, is there is a very organized synchronic response of the system as a whole in the body. And especially with immunization, there's usually an early reaction followed by a clearing of the infection or a secondary wave of immunoglobulin production in this case. But there's a very organized total body approach of this very complicated system in the setting of acute inflammation. Now, in melanoma, the system is chronically inflamed, and the big question that we had was, is the system of chronic inflammation in cancer organized or disorganized, or is it just a wrench that's throwing this whole thing? And is it static or is it dynamic, right? I mean, is it the same every day or does it change? So the first experiment we did in a small clinical trial, we looked and measured CRP, C-reactive protein, which is the most common measure that we use in the clinic to quantify inflammation. And we measured it over several days in a patient with a newly diagnosed metastatic melanoma. I simply asked the question, is this thing going to be constant which is what the assumption is? Remember, this is a measure of immune function. Or will it change? So we did the measurement, and lo and behold, we found that it changes. And it changes in a predictable fashion. What's interesting is above here is an abnormally high level, down here is a normal level. And this particular biomarker has been studied in multiple cancer settings to both correlate and not correlate with clinical outcomes of patients in which it was studied. My question was, when was it measured? Here or here? So what we did is we looked at this data and I said, well, what's interesting is, could there be an immune activation and inactivation phase that's taking place? So something that sort of pushes immunity to an activated state and then shuts it down. And could we, by using relatively inexpensive chemotherapy, just deliver it at this high point here just before the shutdown sequence goes and achieve clinical benefit? You know, keep more immunity to kill more cancer. Made sense. Did a small clinical trial, 12 patients. We had enough data for 8 of them. And I'll walk you through this slide. What basically happened was patients 1, 4, 6, 5, and so forth, we measured CRP levels at about 2 to 3 days over a period of 2 weeks, designed waveforms that I could best do on Excel spreadsheets, and tried to predict when to give a 5-day course, and this is day 1, 2, 3, 4, and 5, of a drug called temozolomide. And this drug was delivered in this block of 5 days, and unfortunately these were the sweet spots. These were the times of the black arrows when we had the optimal CRP concentration to look at outcomes. So we did that, and here are the progression-free survival times. And this is the time until a tumor reaches 20% growth in its volume. And what you can see here is that 2 out of these 8 patients were in fact cured of their melanoma. Now, how does this stack up? Well, if the drug temozolomide is given to patients with advanced melanoma, and we look at 4 months and ask the question, how many patients have no tumor growth 4 months after the diagnosis that were treated with this drug, we get somewhere about 18 to 17%. So in our study of 12 patients, we got a little bit double than that. So that was interesting. You know, all I basically did here is give the patient their drug, not on the day that they had an appointment to see me, but on a day that's synchronized with their body's immune response to the tumor. So can we do better? Turns out other biorhythms also exist in immunity in patients with cancer, in other parameters that regulate the immune response. And some of the most critical on and off switches of immunity, as far as hormones of immunity go, oscillate in patients with advanced melanoma in directly opposite phase. You know, you press on the gas or you press on the brake. They oscillate at the same period, opposite phase of each other. And what happened is that drove us to design a clinical trial looking at this oscillatory counterbalance between these 2 hormones, IL-12 and IL-1RA. And we figured out at that point that we needed to measure blood tests of these parameters, not every 2 to 3 days or, when we had time, but actually did it continuously for about 12 days, essentially 2 weeks. We predicted the biorhythm of these and then delivered at the summary point of both of these 2 concentrations. And we did the interim analysis in the first 10 patients that we did this in, and we wanted to see, how is this stuff working? Where is this thing going? So you remember this slide where I showed you earlier, where modeling therapy delivery on the CRP peak gave us a little bit more than doubling than random delivery of the drug. And here's what happened when we modeled this to IL-12 and IL-1RA. We got approximately 70% of the patients were already doing better than expected. Can we do better? We should try to do better. I really think so, but it's a little bit complicated. And what we're running into is really 2 issues, is the biology. As we started to study regulation of immunity as a function of the cancer, as the malignancy tries to co-opt the body's immune system to its own advantage, we found out that this is very much how the placenta regulates immunity during pregnancy. So right now, I've actually just completed a clinical trial in women in their first pregnancy trying to understand how things are regulated during placentation because this whole system goes back to normal at time of delivery. So can I understand through normal pregnancy how to, quote, deliver the cancer? What's also happened is we've needed to really beef up our analytical capacity, because all of a sudden we're not measuring single dots, we're measuring waveforms. And the statistics of waveforms have really required us to really develop collaborations with applied mathematicians and engineers, including engineers from NASA that have been involved in this project. And this is essentially how the system works. We start here, we collect blood on a patient, we look at the various measurements that we do, looking for correlations or anti-correlations between individual measurements that we analyze. We look at the periodicity of some but not all of these correlations, and then we predict what the optimal time of therapy, and then measure that prediction at the day of treatment that we feel we reach sort of that sweet spot to give the treatment. Deliver therapy, evaluate response. So of late, what we've really done is try to focus on these predictions. Remember, we're trying to predict into the future when a certain series of immunologic events will take place so that we can deliver a disruptive signal, break that up, and allow the body to reset. And here's basically essentially this is a cell count and this is a concentration of a hormone of immunity. We're now looking at a panel of 52. And on the yellow line demonstrates where the prediction of treatment was decided upon. And these dots here tell us what the actual concentration, what the predicted concentration of these values is. And here are the actual validated measured concentrations. So our system today, as it operates in its current form, it's about 75% of the parameters that we measure, we can predict within 20% of the actual measured value. So our ability to predict the future is getting better. We're still trying to improve upon this. So where does this leave us? And what have we learned so far? Remember, this is something that has never really been recognized in our field, because things do indeed change over time. When I meet a patient, they're usually sort of a bit of a black box. You know, a patient comes in to see me because they have metastatic melanoma, they have a deadly illness. What do? I do some tests that give me insight into the stage of the disease, how much of the disease do we have, some genetic information that we can use against the cancer. But what's interesting is that the cancer interacts with the body not in a static fashion, but it really appears to be a dynamic fashion. And I've shown you some evidence that one element of the malignancy, namely the immune response, kind of has a to and fro relationship with the tumor, both one that supports the malignancy and potentially controls it. Understanding these dynamics, based on some of the preliminary data I've shared with you, may in fact be therapeutically beneficial, because we may be able to understand and able to predict when some of these events take place ahead of time, intervene upon them, and potentially gain better outcomes. Now, why would I do this? You know, why would I care about this? Well, I think one of the interesting things about this is that if timing of conventional chemotherapy is important, is the drug to cure cancer already here? And the reason I sort of think of these things is very, very simple. You know, cancer drug development is a $43 billion a year business in the United States alone. Drug companies invent gazillions of dollars in testing all sorts of different molecules, only very few of which make it into clinical trials and ultimately into approval. They don't have neither the time nor the money nor the resources to fine-tune and understand how these drugs work, because they need to get these agents approved so they can pay for another 20 million substance screening tests and analysis so they can be brought into work. What we've done is we've basically developed sort of a calculation more than anything else, into which we can take advantage of some of the most available agents for which we have a great deal of knowledge and apply them perhaps in a better way. And how easy would it be if at least part of the solution is treat not today, but on Saturday? Well, who wants to treat somebody on a Saturday? But if I get a 70% greater chance of not dying of my melanoma, I'll come in on a Saturday. So one of the younger people in our lab has coined our study here as the iChemo for individualized chemotherapy, and I think I had to do this for her because I don't see her in the audience. So how does all of this fit together? Well, mostly what I do and what I have done for the last 25 years is study malignant melanoma. And the current timing or this individualized chemotherapy approach tries to bring a level of science into conventional application of existing drugs and existing resources. This fits into the greater picture of our program, which basically targets multiple aspects of this disease, including targeted nanotherapeutics, modulation and simulation of the tumor microenvironment, vaccine development, which is directly dependent on some of these timing issues that I've showed you, melanoma genomics, melanoma diagnostics, placental biology, and immune imaging, all aspects that are currently under study. And invite me next year and I'll tell you about some of these things as well. And with that, the whole point of what I do every day in my job at Mayo Clinic is try to get rid of this. So without further ado, I just want to acknowledge those whose work is here represented and the thousands of patients that have taken part in the many research projects that here at Mayo we have in this disease. Wendy Nevela, Roxana Dronka, and Alexei Leontovich are being critically involved in this project, as have been Martin Ashtown and Brendan Coventry, our collaborators from Adelaide in Australia, and the many people whose money goes into application of the things I've now described to you, as well as our home team, the Mayo Foundation, that lets me get really awesome parking in this place. So with that, I'll end and take any questions.